Good morning, everyone. My PhD topic is life-changing treatments in central nervous system diseases, ventriculoperitoneal shunt, and targeted therapies. My name is Janka Kovács, and I work at the Department of Pediatrics, Semmelweis University. My supervisor is Miklós Garami, and my SMS is Vanda Máté. My vision is to improve the life quality and extend the life expectancy of children treated with brain cancer. And my mission is to provide guidelines for the treatment of diseases involving the central nervous system, like malignancies and hydrocephalus. These are my two ongoing projects. The first is about ventriculoperitoneal shunt, and the second is about targeted therapies. My first project will be a meta-analysis, and it's about investigating the effectivity of antibiotic prophylaxis in preventing bacterial ventriculoperitoneal shunt infections. So 1 to 2 of every 1,000 babies are born with hydrocephalus, but there can be also other reasons which can lead to hydrocephalus, for example, infection, intracranial hemorrhage, and malignancies. The most common treatment is a ventriculoperitoneal shunt procedure, and an estimated 30,000 ventriculoperitoneal shunt procedures are performed yearly in the United States. The problem is that the incidence is still really high. It's between 3 and 20%, and it can cause, for example, 2 times higher mortality and cognitive impairment. That's why our aim is to compare the rate of bacterial ventriculoperitoneal shunt infection with and without antibiotic prophylaxis. Our question is that does antibiotic prophylaxis change the incidence of VP shunt-related bacterial infections? And here the antibiotic prophylaxis will be antibiotic-impregnated shunt with vancomycin and rifampicin. And we hypothesize that the rate of bacterial infection decreases with these antibiotic-impregnated shunts. So I've conducted my systematic search at the end of November 2022, and I had more than 10,000 hits. At the end, I have 27 eligible articles. 4 of them are randomized control trials, and the other 23 are retrospective observational cohort studies. So these are my 2 main outcomes: the incidence of infection and the incidence of shunt failure. This is my main forest plot, which is about infection in a mixed population. Here you can see all my articles, so 4 RCTs, and here the event is the incidence of infection. And the measure of effect is odds ratio, and if the odds ratio is below 1, that it means that antibiotic-impregnated shunt has a protective factor against bacterial ventriculoperitoneal shunt infections. And if it's 1, that means no effect. So here the overall odds ratio is 0.42, which means if you use a standard ventriculoperitoneal shunt, then you will have like 2.5 times higher chance to get a bacterial infection. This is also statistically and clinically significant. So this is my second forest plot, which is also about the incidence of infection, but here I had 2 subgroups based on the age. The overall odds ratio is 0.38, which also means like a 2.5 times higher chance to get an infection if you use the standard shunt. And I would like to highlight that in the children subgroup, it's more significant. My third forest plot is about the shunt failure. This is really important because if you have a shunt failure, then you will have to remove the shunt, and in some cases you will have to use systematic antibiotics for the treatment, for example, infection, and use external ventricular device, and then perform another shunt surgery, which can cause emotional, financial, and physical difficulties. Here I had 2 randomized control trials and 4 retrospective observational cohort studies. And as you can see, the odds ratio is 0.94, which means that antibiotic-impregnated shunt has no effect in case of shunt failures. The reason could be that there are some other reasons which can lead to shunt failure, for example, an obstruction, an intracranial hemorrhage, or peritoneal adhesions, and the infection is just one from the reasons. But we would like to suggest that everyone should use an antibiotic-impregnated shunt whenever it's available and possible, because infection is a really important reason which can cause shunt failure. So we will need more data about this. The strength of my meta-analysis is that I had quite a big population, and the articles were written in 9 different countries. The limitations are that I had only 4 randomized control trials, and in some articles they didn't really have a detailed age grouping, so they only wrote about mixed population. The conclusion is that antibiotic-impregnated shunts decrease the rate of bacterial V patient infections to about 1/3. And the implication is for the practice is to use antibiotic-impregnated shunt whenever it's available, and of course it's like 3 or 4 times more expensive than the standard one. The implication for the research is that more randomized control trials are needed in terms of, for example, shunt failure, and only adults or children population needs to be examined. So right now I'm writing my manuscript. I'm done with the results and methods part, and the expected submission is at the end of May. This is my second project, which is about defining the optimal dose of oral dabrafenib in children treated with brain cancer. About 30% of childhood malignancies are different types of brain cancers, but the 5-year survival rate is still under 75% in children younger than 15 years old with the conventional therapy. The conventional therapy means surgery, radiotherapy, and also chemotherapy. But in case of BRAF mutation, which is based on the next generation sequencing, we can use some oral targeted therapies. For example, the dabrafenib, which showed a meaningful clinical activity. At our department, we also use dabrafenib, for example, for pilocytic astrocytoma patients, but we don't really have human data about how does it penetrate the intact blood-brain barrier. That's why we will need some human data. And our aim is to define the optimal dose of oral dabrafenib in children treated with brain cancer, which can also enter the blood-brain barrier. Our question is that what is the optimal dose of oral dabrafenib therapy in children treated with brain cancer, which can also achieve the optimal dose in the cerebrospinal fluid without significant toxicity. And we hypothesize that with the usual dose, we cannot reach the therapeutic level in the cerebrospinal fluid. That's why we would like to provide some recommendations and establish a guideline for optimal dabrafenib dose to reach the optimal drug level in the cerebrospinal fluid. To summarize, I'm planning to finish my projects in the middle of summer. And this is my favorite quote from Kurt Vonnegut: "Science is magic that works." And thank you for your attention.
I have a question regarding your second topic. How many patients do you have right now who take oral dabrafenib?
Thank you for your question. So right now we have 9 children at the clinic, and we already measure the drug level in the blood, but we will need like about 20 patients. So I still need some time to write an article.
When is antibiotic prophylaxis is necessary, or when is not necessary antibiotic prophylaxis in YP?
So they always use antibiotic prophylaxis. The difference is that like 15 years ago, they only used like 1 dose cephalosporin, but right now they use also vancomycin like 30 minutes before the surgery. And it depends on the hospital whether they continue it for like 24 hours or for 3 days. But they always use perioperative systematic antibiotic.
I would have a question regarding this topic, that we just heard from King Abudai that we would like to avoid the unnecessary use of antibiotics. Do you plan to assess any possible negative impact of the preventive antibiotics in this group? So if there is any problem with this?
So in case of systematic antibiotics, I'm not planning it because they have a clear protocol, and I don't think that I'm going to change it. But there are some studies about the use of these antibiotic impregnated shunts, so it could maybe lead to resistant bacteria, and yes, we will deal with it. So we will consider it.
Yeah, I think it's important because if you talk about a one-dose antibiotics, it's maybe not a problem, but it would be important to see if there is any data behind it.
My next question, was there any difference how long exists the VP shunt, short or long, if there was problem with the VP shunt? How long exist?
So
1 year, 2 years, 1 week, 2 weeks?
So it can, so you can keep the VP shunt for like years if it's functional. If it's functional. So if you don't have an infection or a shunt failure, for years, I would say that.
Correct. Thank you so much.
It was a very nice presentation, Janka. You said that infection is one of the main cause of shunt failure, but you also said that you didn't see any improvement in the shunt failure if they used antibiotic prophylaxis. What can be the reason, or how is it connected?
Thank you for your question. So there are some other factors. So for example, in some articles, there were only neonates. So the age group wasn't the same, and they don't use the same perioperative antibiotics in the hospitals, and the surgeons are not the same, of course.
Yeah, you had a sentence that the treatment was more significant with children. I mean, I would be careful with this because you have a relatively small number of studies and heterogeneity, and so I would rather say that there is a tendency, and this would be important to study. You understand?
Yes, thank
because
you.
Then that opens actually that your final statement actually in the conclusions that more studies are needed because of this and this and so. But I think this is early to say that this kind of treatment is more effective in children. Do you agree?
Of course, I agree.
No, you don't have to. I mean, this is a discussion.